The first thing we wanted to talk about was a tool used to provide a bit of a general assessment, and you can have the patients fill it out in the waiting room. Is often, and we'll discuss later, various ways that people can incorporate this into their practice, but the brief pain inventory is a commonly used tool. It's on the left here, and what it comprises 3 parts. There's a body pain diagram that the patient fills out with often colored pens to indicate different kinds of sensations. It includes a section on pain scores, just to get a general idea of what those are, and a third section on pain interference with 7 different kinds and types of activities that they will do throughout the day. And those 3 things comprise the brief pain inventory, and it's often used at initial and some follow-up visits to see how things are going. You could also instead use something called the pain disability index instead of the pain interference part, and that's David's preference, so I'll let him speak about that.
Well, I used basically 2 elements from the BPI. I used the pain diagram, and I probably make more diagnoses from the pain diagram than I do from any other part of my assessment tool. And my MOA, Barb, is, where is she? Over there. Put your hand up. Thank you. She hands that out. She asked my patients, I was doing a chronic pain assessment, she asked the patients to come about half an hour before I actually see them. And they fill out a pain diagram. I have a bigger one than that in multicolors, and depending on what type of pain. And I'm always astounded by how the patients understand anatomy without having read anatomy books. I see. Just on Monday, I saw a perfectly drawn out L5S1 radiculopathy, and you can make the diagnosis right there just looking at it. I personally don't use pain scores when I'm assessing chronic pain. When I have my other hat on as a GP anaesthetist, and I've got somebody in post-op, and I've got my syringe full of fentanyl, I'll use pain scores. In chronic pain, I don't actually find personally pain scores that useful. Some people do. Other than the issue that Heather said, which is when somebody says their pain is 15 out of 10, they have some issues, and maybe that's around trust and not being believed. The pain disability index to me is your hemoglobin A1C of chronic pain. This is how are you functioning? How is the pain affecting your life? And getting back to what I said about control of the pain, that we're not going to cure. It's probably unrealistic to think that most chronic pain, other than when you have your hip replacement, is going to be cured. Most chronic pain is going to be controlled. And so I don't actually ask the patients how bad the pain is. I talk about how it's affecting their life. And the whole aim of any maneuver that you do should be to get the scores on that pain disability index less.
I use the brief pain inventory in my practice at VGH as well. I like it for the beginning. For pain scores, I agree, I don't use them chronically like I have over time, but I like to see it just up front, just see kind of what the range of the scores is, where they're at, but I don't think they're that useful over the long haul.
I want to introduce you to Wes, who's a psychologist who's standing up over there.
Yeah, just for people who use the brief pain inventory and the interference scores, there's 7 items there, right, out of 10. So a patient fills that out, you add up what their score is, you divide by 7, so you get an average using those 7 items, right? And then on a nice study of about 440 chronic pain patients, the average interference score was 8 with a standard deviation of 2. So that helps you know basically where you're at in terms of other chronic pain patients.
Thanks, Wes. Yeah. And you can use that those scores both at your initial assessment and as follow-up to see how they're doing over time, because you'd like to see those interference or pain disability index scores getting lower, meaning the patient's becoming more functional and there's less interference in their life.
And memory is a weird thing when it comes to pain. I mean, the fact that women continue to have children is evidence to that point. And people say they come and see you 6 weeks after you've done an intervention, maybe relaxation breathing. My pain is no better. Well, they filled in their pain disability index, and by their words, not yours, there's a reduction there in their pain. And then you can bring up the old one and say, well, actually, so pain disability index, really good way of tracking pain.
One thing that Michael and the other specialists asked us to try is that when we're seeing pain patients for the very first time, that we try to fill out the 2 pages of the brief pain inventory to give some background, but that when we're seeing patients for the second time or follow-ups, that if things are too tight, things are too busy, you don't have enough time to go through a 2-page questionnaire, then as you can see on the 2 outside screens, you can skip that first page of the brief pain inventory and just do the second page. And David's point there with the pain disability index is that the last 7 questions are very similar to the questions that are in the pain disability index, and they're the ones that are used as the measure of how the patient is doing from visit to visit and over time, as Wes was mentioning, being able to get an average score or look at specific scores.
So yeah, in summary then, the 2 things we find most useful about this is a body diagram and the interference scores. Those are kind of the main points. The rest of it you can kind of fit in with your history. The pain catastrophizing scale, and this was created by a psychologist named Mick Sullivan at McGill, and this has been his whole work for his 20-plus year career. Catastrophizing is a concept that applies not just to pain, but actually across other types of disability. That means a person has catastrophic thoughts about their condition. And it involves 3 things: rumination on the thoughts, magnification of the symptoms, and a sense of helplessness. And this is designed, there's 3 subscales in there, but you don't know what they are from looking at them. But the patient simply rates all of these and then says either it's never at all or I get this all the time, and you add it up and have a score. The reason we've included in here, it might sound a little bit more specialized or that's something for a tertiary clinic, but the reason we put it in here is that catastrophizing, when it's present, is highly persistent if you don't do something about it. It's modifiable, so you can do something about it, and it's highly correlated with disability and not getting better, basically. So if you identify catastrophizing as an issue, it's important because all the other stuff you're doing might not help very much unless you begin to address this. Now, it can be addressed a number of ways, even just education and reassurance and all the stuff we do often will help reduce that, but you got to get into it a little bit, and it's.
I think it's fair to say it's going to sabotage everything else that you're doing, isn't it? And this is actually a scale that I've only just started to use in the development of this module. I didn't use it before, and I've just used it a couple of times now, and it can bring out some really good talking points for your patients.
Yeah, it was used a lot in, or developed a lot in the workplace accident type of injury with predicting pain and disability chronicity, basically. And the concept applies across other disease conditions too, predicting disability from chronic health problems, essentially. So we've put it in here to see kind of how it plays, basically, in the GP offices. And the feedback we got back on the trial was that, yeah, I can see where that might be useful, or I'm a little afraid of the word catastrophizing and how I'm going to decipher that for the patient because I don't want them to immediately think that it's all in their head. Others have said, well, I can use this again, like Wes said, as a teaching tool where tell me more about this, or I can see you're getting better in this area. One thing we did in the handout there was, from feedback, we took out the word catastrophizing and just called it PCS. Another way. I think using the word catastrophizing may or may not be helpful sometimes, and if the patient has enough insight, they might be able to realize, well, okay, I get what you're saying now, that I actually am, I'm magnifying and thinking about these thoughts more than I should be. Wes, do you have any comments?
I'd suggest that you use the word alarm thinking, which I guess is 2 words. And you can do that because when people have pain, their whole system gets alarmed, right? So they will get that. If you, yeah, I feel really alarmed about this pain. My body feels all uptight, and I feel really quite worried and upset. And then you make a link to the thinking. Their thinking is alarmed as well. And then you're going to ask me, right, what do I do with that? How do I intervene with alarmed thinking? And the fast answer is, I wouldn't go with cognitive behavioral therapy right away unless you have time. I just go with some quick mindfulness tool, maybe just a quick thing that David's going to do about breath work. Very simple, that you help them to diffuse that kind of alarm everything by paying attention to their breathing or doing a quick mindfulness little thing, which you can show them in the office.
Next tool we wanted to introduce, and you probably are familiar with it, some of you anyway, is the DN4, which stands for douleur neuropathique, because it was invented in France. It's a neuropathic pain screening questionnaire. Some people found this useful, some people not, because they kind of ask about questions around neuropathic pain in their history. It's quite easy to use. You can fill out part of it, or you could have the patient fill out the top half. The top half is from interview, the bottom half is just what you see on physical exam. And essentially it's just going through, the top ones are 7 types of characteristics that would imply neuropathic pain, and the bottom 2 are, is there hypoesthesia to pinprick or touch in the area of the pain, and is there hypersensitivity or allodynia in the area of pain? So, and if you have 4 or more, it's indicative of a positive result and highly likely to be neuropathic pain.
This can also be helpful if you run it with the pain diagrams, where you're using different colors for different types of pain. And you can say, oh, I see you wrote, I use blue for tingling, and then you can run it with this as well.
And just as an example, we often think neuropathic pain is pretty easy to recognize. You know, if you have postherpetic neuralgia or diabetic neuropathy, you kind of know what you're dealing with. But it can be subtle and very mixed with nociceptive pain sometimes, and it's actually not that. It's not hard to miss it sometimes. I just saw 2 patients the other day who both had long thoracic scars on their spine from long time ago scoliosis surgery, with chronic pain at sort of 1 or 2 spots just to the left of their spine. And something in the history kind of made me think, because everybody was looking for mechanical causes and discs and facet joints and doing injections, and I looked at them, and something in the history kind of tweaked me a bit, and I examined them, and they had these big areas of numbness, and some of them had, you dig into it a bit, they were itchy in that area, and they'd scratch it till it bled sometimes, and just stuff that didn't really come out in a normal kind of interview, but you had to dig into a bit. And I'm sure they both had neuropathic pain, and if you had asked them to do this questionnaire, they both would have scored 5 or 6 basically on it. And so it can be useful, or even when you're not thinking of neuropathic pain, like someone who's basically walking, there's no neurologic injury, they just have some numbness around the area of the scar and some neuropathic pain in that area. So it can be useful in more ways than you might think. So the opioid manager is, if we're talking about wanting to put somebody on some opioids for chronic pain, then you really need to go through a bit of a whole process of evaluating that patient, maintaining them, following them, and taking them off if it's not appropriate. It's the whole concept of an opioid trial. And probably many of you are good at doing this already. You may or may not use the opioid manager, but a lot of people are not good at this and just don't really have a process, and then later on they're trying to extricate themselves from a tricky situation. So the National Opiate Use Guidelines came out in 2010. This document was created as part of those National Opiate Use Guidelines. We've included this as one way that you can use to manage an opioid trial for people, but there are others, and you may have your own favorites, and people out there in the community may have their own favorites, but we wanted to just introduce it to you as a multi-component document.
I think Michael hit the nail on the head there when he said an opioid trial, that opioids are just one of many tools that need to be employed in chronic pain. And to be honest, I don't use the opioid manager, but I would advise everybody to read through it so that you have a game plan of how you're going to start and how you're going to stop if it doesn't work. I use parts of the opioid manager myself. I use the opioid risk tool just to get me thinking about how difficult or easy it's going to be to do opioid trials on my patients. And frankly, if they're scoring 8 or more on the opioid risk tool, I am not going to be doing an opioid trial, at least not without significant help from other health professionals. Frankly, if they're scoring more than about 5 on the opioid risk tool, I'm having worries about this. But certainly if they're 8 or more, if I'm ever going to make an opioid prescription, that I'm going to do it working with some other drug and addictions and other chronic pain specialists.
There may be an expectation that before initiating anybody on opioids that this is something that you should run. And as far as if you're using it from the algorithm, you can see this opioid risk tool here. If you check the boxes, whoops. If you're checking the boxes, they'll just check, and you can check whichever ones you want. And as you go down to the bottom, you'll see that there's a auto score feature that will give you the score. And when you look down in the red there, you'll see what the scoring risk is. You can print that form out at the top. Remember that little print button, and you can include it in the chart for the patient. And then the form can be reset by clicking on the reset button, and it goes back to 0 score again.
Or alternatively, you can give it to your patient before they come and then scan that in later, depending on whether you're a computer geek or not.
One thing about the opioid risk tool to know is that you score it differently whether the patient is female or male. And that's why there's 2 lines there. If you give it to your patients, just be aware it's possible for them to get confused by the first question, which is family history of substance abuse. And then they look at it and they see a column for male and a column for female, and they think, oh, my father had alcoholism, they tick that. My mother had drug abuse, they tick that. So that can kind of mess up their thinking for the whole questionnaire. So if you're going to give it to patients, just explain, okay, you're a woman, you fill out this part down this aisle. That's just a little caveat. I've noticed people sometimes fill it out wrong. So the opioid manager, and you should have some kind of a process, and the opioid manager keeps you on track that way. The first part is jam-packed with a bunch of information about before you start a trial, assessing them, make sure they have an indication for opioids, that you know about the risks, and et cetera, and you've gone through a consent approach. And one of the most important things I think you need to do, and this actually applies to any kind of therapy really, for pain, is what are the goals? What are we actually trying to achieve here? Is it pain reduction? Well, that is probably part of it, but you really should encourage them to find other things too, functional goals. I want to sleep 5 hours a night again. I want to go out for dinner with my wife once a week and not have to leave after half an hour because I'm in too much pain. Whatever they are, just get some very concrete goals, and then you can use those as a way to assess whether your trial is actually helping or not. Because without that, if you're into any kind of trouble or you're worried about aberrant behavior, it doesn't matter. They're going to say, well, I'm better. Well, how are you better? Well, you got the goals then.
You could use the Pain Disability Index as well for assessing that.
The checklist is on the opioid manager, and it just runs through that you've kind of done a consent process basically with them about why you're doing this. What are the risks? What are the proposed benefits? You've given them some information. You may or may not use a treatment agreement. Some people do, some people don't. The treatment agreement is just a written form that says you went through all these consent things, which you should do anyway for any kind of trial, whether it's tricyclic antidepressants or whatever. So it's really nothing magical about it. It's just more to make sure you did it, that you've gone through some kind of process to explain why we're doing it and what the risks are. Urine drug screening as needed. Again, some people do it, some people don't. It's not a panacea. It's not going to solve everything, but you are often surprised by what you find in people that you would have never thought you had any reason to believe there was any drug abuse problems. And it's not to catch people and punish them, it's to identify risks and to help them if they have a problem.
So my record is cocaine in the urine of a woman in her 70s. And I was as surprised as she was when I discovered it, I think. But no, she claimed to be surprised. Her grandson gave it to her, so she said. I do routine urine drug screens on everybody when I'm doing chronic pain assessment. And the reason I do that is it takes out the stigma. It's nothing personal. I just do it on everybody because I'm not smart enough to work out who has problems with drugs and who doesn't. And furthermore, I'm not smart enough to manage chronic pain if you have some other drug issues. And
there is several commercial urine drug screen kits that you can buy that are dips just like the regular urinalysis that you can run in your office. And there is an MSP billing code that's, I believe, for $15 and something cents, which more than covers for the cost of the kit, which I think is around $6 or $7.
Do you do it, Bruce? Do you do it in your office?
Yes, we do. And I wanted to add, the challenge is that so far the 2 kits that we've used have shown some surprising results. So we're getting some unexpected false positives. So someone that's on hydromorphone, it's showing some positive for another opioid that we weren't expecting. And so any unexpected results that we get in our office, we automatically, before we confront the patient and challenge them and tell them that they're terrible people or anything like that, we send the urine off to the hospital lab or whatever lab for confirmation. And so far, almost all of the ones that have been unexpected in our office have been not confirmed by the hospital test that in theory, I guess, is more detailed. They use different methods of testing. So you might ask, well, then why do it? Well, there's many times when it is expected to be what you see what is expected, and so everything works out fine. But it's certainly, there's been enough surprises where we've had confirmation, and we'll talk about that more in the small groups, that make it well worthwhile to do the urine testing, at least on a random basis.
Well, I would argue that the more commonly you do it, the less stigmatizing it is. So I can just say, everybody does it.
So we talked about the opioid risk tool already. There's different ways you can have it formatted. When you do an initiation, there's all kinds of information on the opioid manager, again, about the various types of opioids. And it gives you a place to chart all of the information about how that trial is going. When you saw the patient, what was happening. It prompts you to ask about how things are going with the analgesia, the adverse effects, their activity level, and whether or not there's any aberrant behaviors that you want to kind of monitor or ask the patient about, like losing prescriptions or running out early, etc. So there's a whole chart there on the various opioids, and you can find these online or in apps as well. And then through the maintenance phase, once you've established that it's kind of meeting your goals, now it's just maintaining it and making sure you continue to ask the questions and check in on them. And notice if there's problems or the dose needs to be creeping up. Why is that? What's going on with the goals and in their life, and important in some way to document that. And as we say, the opioid manager is one way to do it. There's a chart on equivalent doses, and again, this is always a little bit controversial, and you'll find discrepancies from one chart to another. I think if you have a ballpark number in your mind and know that a lot of the studies are based on single dose studies, and when you have multiple dose over a longer period of time, the equivalency ratios change a little bit.
Why do we have mepiridine down there?
Yeah, meperidine is still in there. You should not be using meperidine for chronic
Don't use
pain.
meperidine for chronic pain, okay? Don't use it.
Yeah, and one of the big reasons not to use it is that its metabolite is neurotoxic. So if you get into doses 500, 600, 700 milligrams a day, people can have seizures from meperidine metabolites. And that's worse if they've got liver or renal disease. So I saw somebody just the other day, he came in on, he was taking 500 milligrams of meperidine, and I was surprised because I hadn't seen that for years. And I told him why, and he's like, wow, I didn't know that. You know, there's no reason. He thought hydromorphone didn't work for him, and it didn't work for him because he just didn't get enough of it for his condition. So we rotated him off of meperidine onto hydromorphone, and there's no problem. It was just a matter of it wasn't explained to him why this was a risk, and that there were other ways to do it. What do you do when you need to decrease the dose or stop the dose completely? When the condition's resolved, when the risks are outweighing the benefits, when the adverse effects are outweighing the benefits, or when it's just simply not effective. In other words, you've set your goals, you tried your trial, you're not meeting any of the goals, they're not really better, even though they might feel like, well, you've decided what the goals are and they're not being met. So you have a discussion about weaning them off, just like you do with any other drug. I see lots of people who stay on gabapentin and nortriptyline and all kinds of stuff, but it's never really been asked, is it really helping you or not? I see them and I say, do you think it is? They don't really remember. I say, let's try to come off of it a little bit and see what happens. And oftentimes you get the dose lower or off because it really wasn't doing anything.
So this is where your pain disability index might come in. You know, if somebody's been on a trial of approximately 200 milligrams of morphine equivalent for a decent amount of time, and their pain disability index is still 70 out of 70, something isn't working, right? So why would you carry on prescribing that drug if you're not affecting that patient's life in a positive way?
The last tool we wanted to talk about was the RACE line, which stands for Rapid Access to Consultative Expertise. You may know about it already. It was an initiative between the Shared Care Committee and Providence Healthcare to have their specialists be on the phone for GPs in Providence Healthcare. Now, some of those services have expanded and become provincial in scope, and pain is one of them. So myself and 5 other specialists will take calls to answer quick snappers, have a little mini hallway consult, whatever you want to talk about. And if it gets too big or too much, we'll say, well, someone's going to have to see that patient because we can't deal with the whole thing on the phone. But it's been quite useful. I've learned a lot from about what you folks are facing and trying to deal with. I've learned I can't always answer your question as concisely as I want, but I've been able to point you to resources and just reassure people sometimes that, yeah, what you're doing is right, it's the right direction to go, and this is what to look for. So it's there to support you as well, and I think it's worked quite well.
You've heard David say, you know, the pain disability index works for him. I've told you the brief pain inventory works for me. Everybody's different, and it all works differently. So try these things out. And instead of, you know, I'm really impressed with the doctor that I was telling you about that's done all the tools. If you find that that's too onerous, pick one. Brief action planning on yourself. Pick one thing, challenge yourself, have a partner with it. I mean, I've done that with my partners in my practice when we were doing these things. Is we did brief action planning between us, you know, in a week-by-week check-in thing, and trying these different tools out. Think about that for this afternoon at the end. It's overwhelming. It's a lot of stuff. We all feel anxious about pain and have that, as David said, that feeling, that sick to your stomach feeling, like, oh no. We've had that before. Let's make it different. Let's change that. And this is the opportunity to do it.